So good afternoon, everybody. First of all, I would like to thank Sudha Madam and Papa Madam for giving this wonderful opportunity. So coming to the topic, is laser losing its importance? So studies have shown that in PDR, both anti-VEGF and PRP treatment has got similar results regarding the visual acuity and control of neovascularization, but anti-VEGF has got its own advantages. So first of all, coming to the basics of laser, you all know the mechanism of action of PRP. There is destruction of the photoreceptors in RP, which is the most metabolically active cells, which decreases the oxygen demand, thereby decreasing VEGF, and also it decreases vascular permeability. Regarding focal laser, it targets on the leaking microaneurysms, which will help in resorption of fluid, and it improves the oxygenation and thereby decreasing macular edema. So there is a general trend that PRP means just a few laser shots around the arcade. So we'll see what is the most appropriate technique. First of all, the settings of PRP, the spot size, it is you can remember by the 200-200-200 rule. That is spot size at 200 microns, duration 200 milliseconds, power can be kept at 200, spacing 1 burn width apart, and the total number of burns can be 1500 to 2000 in 2 settings. In focal laser, the spot size and duration is lesser than PRP. Now coming to the extent of laser, how anteriorly, laser shots can be given up to the equator. Equator can be identified by the ample of the vortex veins. And the posterior extent, superior and inferior quadrants should be given just outside the arcade. Nasally should be given up to 1 to 2 disc diameters away from the disc, and temporally 2 to 3 disc diameters away from the fovea. But certain areas should be avoided. That is 3 and 9 o'clock position should be avoided as there is a long ciliary nerves, then ample of the vortex veins, over major retinal vessels, and also directly over the pre-retinal hemorrhage and chorioretinal scar. Now coming to the complications of laser, the most important complications according to the patient will be night vision difficulty, defective color vision and field restriction. Also other complications are aggravation of macular edema, appearance of choroidal neovascularization, subretinal fibrosis and secondary angle closure glaucoma. Now to tackle all these, we have the newer laser techniques, that is multi-spot laser. We have the Pascal laser where the laser shots are given in a preset pattern. Up to 64 spots can be given at a time. So it will reduce the exposure time. Then we have the subthreshold micropulse laser where laser is divided into short repetitive pulsar. We have an on time and an off time. So this off time is helping for heat dissipation and it decreases the collateral damage. Now, next is a targeted retinal photocoagulation. Here, the peripheral, non-perfusion and ischemic areas are identified using an ultra-wide angle FFA, and these areas are targeted for laser. So, we can have fewer laser points. It will minimize the complications of laser. Now, next question is, which is preferred, laser or anti-VEGF? So, we will see some clinical scenarios. This is a patient with center involving macular edema. Here, there are many studies to support that anti-VEGF is the treatment of choice, and also it has an advantage that it will promote the regression of diabetic retinopathy also. Next is a non-center involving macular edema. Here, focal laser is a good choice, and it is usually preferred for extrafoveal succinate maculopathy and also in conditions where anti-VEGF is contraindicated. Now, next is PDR. Here, anti-VEGF and PRP has got similar results regarding the anatomical outcome, control of neovascularization and also visual acuity outcome. But anti-VEGF has the advantage that it has a better visual field, the diabetic macular edema and vitreous hemorrhage incidence is lesser, and also there is a less progression of PDR. Now, next important factor in our setup will be the patient compliance. Anti-VEGF treatment requires more intensive treatment plans. The patient compliance is a very important factor. So you should talk to the patient regarding the available transportation to the clinic, the family support and the work-related issues. And also multiple injections has got the risk of endophthalmitis, and it is not preferred for patients with multiple comorbidities. So if patient compliance is a problem, then PRP is preferred. Next important factor is the cost factor. You know, the average number of injections. We usually advise monthly injections for 6 months, and after 6 months, again reassessment is done regarding the control of neovascularization. If it is not controlled, again monthly injections for 6 months is advised. So we can imagine the financial burden the patient has to take. So if cost factor is a problem, again PRP is a preferred mode. So personalization of the treatment plan is a key factor. We can combine laser PRP and anti-VEGF, but it requires more studies. Thank you.
Thank you.